Good afternoon, everyone. Thank you for joining the Cure Cancer Lunch and Learn this afternoon. I'm Nikki Kinloch. I'm the CEO of Cure Cancer. Today, we have the honour of talking to one of our new researchers for 2023, Dr Asmerom Sengal, who's based in Queensland at the University of Technology. Our session will last between 30 and 45 minutes. And if you do have any questions, please type them in the chat box in Facebook. I will then incorporate these as we go along. And please don't feel afraid to ask questions. This is the whole point of these sessions. If you're tuning in from Facebook, you may notice a donate button popping up or a link to the donations in the comment section. If you are able to, please consider making a donation of any amount to support our cause. We deeply appreciate your generosity. Also, if you haven't already, please like and follow our page to stay tuned on our Lunch and Learn sessions. We have one every month. Our goal is to raise awareness about the critical need for cancer research funding, and your support means a lot to us. These small gestures can make a big difference in keeping the conversation going and driving progress towards a cure. As I said, today we have the pleasure of having one of our brightest young researchers in Australia tell us about his work and answer some of your questions. Dr Asmerom's research delves into endometrial cancer, the most common gynaecological cancer in Australia, with approximately 15% of newly diagnosed patients sadly dying from their disease. His long-term aim is to develop personalised therapies for those with advanced endometrial cancer to improve outcomes, increase enrolment of patients into clinical trials, and to lead more treatment options. We are here to learn about his plans, what goes on behind the scenes of his research work, and what he hopes to achieve with his project. So please give a warm welcome to Dr Asmerom Sengal. Asmerom, welcome to the Cure Cancer Lunch and Learn.
Thank you, Nikki, for having this opportunity, and it is a good opportunity to introduce my research work and probably increase the awareness of endometrial cancer. And this is really a good opportunity also to share what is going on as you described it. So, yeah, welcome.
Lovely. Well, thank you. I think the first question we'll kick off, and you and I were just chatting behind the scenes. Obviously, you're not originally from Australia, you're from a newish country, Eritrea. Did you want to start by telling the audience a bit about yourself, your background, and where you grew up?
Yep. Yeah, I'm Asmerom Sengal. I born and grown up in a small town called Adikola in the south region of Eritrea, East Africa. I completed my elementary, secondary in my hometown, and started my med school in my country, and then it is a kind of mixing with Cuba Latin America School of Medicine. So I graduated my medical school from Latin America School of Medicine. Then I worked for 2 years as a GP in my home country, and then I joined to do my specialization in pathology and at Jazeera University, Sudan. And then after finishing the specialization, I joined to do a PhD in QET to proceed my PhD. And then stuck in Australia, in lab, and then working in the research area.
Wonderful. So as a little boy growing up in Eritrea, what made you interested in medicine and research?
Yeah, man, it is just from my childhood hobby to become a doctor, even though I don't know what was the setting, but from my childhood, I was just saying I will be a doctor. I was inspired by the doctors and nurses that are in the hospital. So but later on realized med school was not in Eritrea. So I started initially with medical laboratory science, that is the nearest to the field. And then when the opportunity comes, I joined medical school.
Wonderful. And you've got quite a unique background that a lot of our emerging researchers don't have, which is being a clinician as well. So, you know, you're a GP clinician and now in research. That gives you a unique understanding of the impact to patients as well.
Yeah. I mean, the most important for pushing me to research is the challenges that I was seeing when I was a medical student. I have noted early my starting clinical practice, cancer was very challenging for both the patients and the clinicians. So I observed there is a gap in the management of the cancer patients. Since then, I really start to think on how to improve the treatment of cancer globally, and that is the reason behind that I joined from clinical to research, just to involve in teams that can just change the current practice of management of endometrial cancer.
Yeah, absolutely. And then what brought you from, you went, as you said, to Eritrea to Sudan and then over here to Queensland? Why Australia and Queensland?
Because in the region there is no well-established research area training except the basic clinical research, mostly the routine from the clinical practice. There is no really good research area. So one day I come to chat with my current supervisor, Pam, and I realized that Australia has the best health system and the best research infrastructure. One of the most innovative researches being conducted in Australia that really impacted the outcome of patients. So keeping in mind this, it was the first choice to move to Australia if I get the opportunity. Then, fortunately, I get the opportunity to do a PhD scholarship with QUT and start my PhD training in Australia in late 2016.
Lovely. So how was that transition? I imagine, I mean, we were just talking before, I haven't been to Eritrea, but obviously I imagine it's very different to the surrounds of QUT. How did you, I mean, obviously you've been here a considerable time now, but how did you first find that move from your home country over to Queensland?
It is quite different setting, different environment, and different cultural aspect. Initially, I was a bit challenged to cope and set the lab research because my background was a clinician. I wasn't really trained in all the lab work, so I need to train from scratch. And when I started my lab, it was a new lab also because I started a new project in my PhD project. It just took a significant time to setting up and get used to the system. But once I set up all this, I found it very interesting. And I love the research area, and it is a good experience. Since then, I'm progressing very well on the research area.
Lovely. Well, thank you for sharing that and some of your background. So let's talk about your research. You touched on how you moved from being a clinician to being a researcher to be able to understand cancer and the treatments better.
Yeah.
Why did you decide on focusing on endometrial cancer?
Yep. Endometrial cancer is really an exceptional cancer in terms of its burden and mortality. It's only a cancer that is increasing in incidence and mortality, even though Australia is progressing very well, but endometrial cancer is an exception. So there is a gap in the management area and in the overall in the research area of endometrial cancer. So I realized that when I just approached my supervisor, there is a gap in this area. Mm-hmm. And then I started to work in endometrial cancer. And I found really interesting in this field to address the gap. And of course, there are still challenges that we need to address, and then that's why I'm working on that.
Okay, and you mentioned, if I'm correct, that the incidences of endometrial cancer are increasing. Is that right?
Yes.
Wow. And why do you believe that's the case?
One of the possible explanation for the incidence, this dramatic increase incidence over the last 50 years is the population dynamic and the societal obesity, because endometrial cancer is directly related with obesity. It is one of the risks for development of endometrial cancer, and obesity is one of the major issues in the developed countries. So it is directly related to the obesity, because it is very rare in the low-income countries with less obese society, but very high in the burden in the developed countries. So the reason that could be increasing is also the aged population, because cancer is usually increasing with aging, the incidence. So both the aged population and the dramatic shift in obesity could be the reasons that are increasing in incidence.
That's very interesting you say that, because we also have a researcher that we're funding in the last 2 years, Dr. Shafiq Syed. He's looking at the link between uterine cancer and obesity as well. So he has said that he started his work career in India, and he has said something very similar, that the incidences in the Western world are higher because people want to live longer, but two, they have a higher sugar diet, and therefore there's higher incidence of obesity as well.
Yeah, true. Because obesity, and this is a female hormone. The estrogen is the most significant contributing to the growth of the endometrium, because when there is excess estrogen, the reproductive hormone, there is likely the endometrium get thickened or proliferate or grows, and this is a fertile background for developing cancer. So there is a direct association between the higher body mass indexes and the estrogen level also, because physiologically the body starts to produce more estrogen hormone, and this is the reason behind it.
So let me just repeat that to make sure I understand. So if you suffer or are obese or have a higher body mass index, as a female, you produce more estrogen, which can then help drive the incidence of uterine and other gynecological cancers. Is that correct?
Yeah, correct.
Interesting. Thank you. I understand you also do some work on breast cancer as well. Why did you do the research on that, and how is that related to the research on endometrial cancer?
I was working in East Africa when I was training in pathology. So basically, the breast cancer was I just was looking for is there any difference between the Caucasian and the East African population? So yeah, there is some connection, of course, with breast cancer, but the direct relation is not connected because they are independent cancer. Now I'm focusing on endometrial cancer, but I'm expanding also because I'm developing biomarkers that are useful for like informing the treatment response, or that can just be biomarkers that are related with unresponse treatment. So the markers that are discovered are also applicable to breast cancer. So this is a plan to expand into breast cancer and other cancers.
Understand. Thank you. I'm just going to pause there and welcome our new participants. Welcome aboard. This afternoon, I'm doing a lunch and learn with Dr Asmerom Sengal, who is focused on endometrial cancer at QUT up in Queensland. So we were just talking about your work on endometrial cancer, and you touched on the biomarkers. Did you want to explain what biomarkers are and what you're doing in relation to them?
Yeah, sorry. Yeah, the biomarker I'm working is called fibroblast growth factor 2, because there are different types of growth factors. So one of them is a fibroblast growth factor 2. And this growth factor receptor, it is expressed on the cell surface of the cancer and the normal cells, because there are different variants of the growth factor receptor. In normal cells, they express one variant, and in when they develop cancer, it shifts to other variant, which is very important for the cell for growth, and also just escaping the mechanism of the immune system to track the cancer. It just involves in several what we call the hallmarks of cancer, means so all the pathogenesis that involves for aggressive type of tumor.
Mm-hmm.
And this biomarker is found to be in endometrial cancer expressed in 30 to 40% of the population, and it is related or associated with poor prognosis. If the patient have this biomarker, they are likely not responding to the conventional therapy,
Mm-hmm.
and they have poor outcome. And then this biomarker is also have a similar effect in other solid cancers. So we are trying to target this cancer,
Mm-hmm.
as well as to identify as a biomarker of treatment response.
Lovely. So let me just repeat that to make sure that I understand. So these biomarkers are similar biomarkers that you find in patients with breast cancer and other solid cancers.
Yeah.
But 40% of those people that have them are not going to respond to the traditional pathways of treatment that you give other people with this type of cancer.
Yes, true.
Okay, and when you're looking at the patients or the biomarkers of the patients, are you looking at all patients with endometrial cancer, or are you looking at those that you know haven't responded to other treatment pathways?
Yeah, first we general screen in the population from a cohort. It is an international cohort. And we just screened over 460 women with endometrial cancer. And there are particular subtypes that are more likely to express a marker. Not all endometrial cancer express this type of marker. So there are we have new molecular classification in endometrial cancer. They based on their molecular characteristics. So it is expressed more commonly in the two types of endometrial cancer molecular subtypes. They are called the mismatch repair protein deficient. This is one classification, and the other is that doesn't really express the mismatch repair protein. So it is more common on this type of molecular subtypes.
Interesting, thank you. And you talk about typical treatment or normal treatments. So what would someone that has got endometrial cancer, what would they typically go through as a treatment plan to see if they respond to that?
Yeah, so in endometrial cancer, generally, like once they diagnose it within the uterus, the first option or the standard of care of treatment is removing the uterus and the ovaries. But if the tumor expands beyond the uterus, the treatment is quite challenging. So the conventional treatment is radiotherapy and radiochemotherapy, but not all patients with if it is metastasis or spread to other bodies of the, it is not responding well to this conventional treatment. Now, there is a new emerging treatment, the immunotherapy. And this is particularly useful in women that have the molecular subtype that before I mentioned, the mismatch repair deficient women.
Yep.
But the other are less responding to immunotherapy too. So still there is a challenge in the management of endometrial cancer, and unlike the other solid cancers, there is limited treatment options when it is really spread to the body. So we need to find a more effective way of treating the metastatic cancer, because 90% or more than 90% deaths are related to metastasis.
Wow, that's very high, isn't it?
Yeah.
And also, just to go back to something you said about the normal treatment plan is essentially a hysterectomy.
Yes.
You know, I remember Dr. Shafiq saying the same. Why should a woman have to choose whether she survives or doesn't have children? You know, that shouldn't have to be a choice.
Yeah.
Whereas still in 2023, that is the choice that these unfortunate patients have to make, which is very sad, isn't it?
Yeah, just thank you for reminding me this part of the challenge, because I'm still working on that area, because in endometrial cancer, like for example, about 20% they may be younger that not complete treatment. I mean, for their reproductive plan or childbearing plan. So if they develop the cancer, the only choice they have is to remove the uterus, and if they remove the uterus, it is unlikely to get a child. But still, they are ambitious to have a child. And then there is a hormone, which is the progesterone hormone, that is given to women who are wishing to preserve their in their uterus, and this is still not effective, especially if it is developed into cancer. Only 40% are responding. So there is a need on this area, and we are working. Our lab is working on this area, so to develop a biomarker of treatment response, whether they respond or not. So if they are not responding, they are likely to have the hysterectomy, or a better alternative of treatment that adds with the hormone treatment. So yeah, this is a there is the gap that is still exists. Yeah.
Absolutely, thank you. So you talked about how you're looking at biomarkers that can look at a better treatment, particularly for those people that don't respond to either having a hysterectomy, or if it's metastasized, then they would have radiotherapy.
Yeah.
So how are you progressing in this? What is your hope with this research? Where do you want to end up with this project?
Yeah, with this project, we have almost clear the preclinical testing. So we have tested in a cohort of patients, and there is a drug that is targeting for this biomarker, and it is clinical available. So we have tested in mice the treatment, and they found the tumor that expresses this biomarker was found to be highly sensitive to the treatment. Wow. So we are now moving to initiate clinical trial and waiting for funding.
That's incredible news. Well, congratulations on getting that far. I just want to pause there and welcome everyone that has joined us. I see a few more people have just come along. This afternoon, we're talking to Dr. Asmerom Sengal, who's looking at endometrial cancer up at QUT in Queensland. Just a reminder, if you have any questions, I'm happy to incorporate them into the chat. Please just drop them onto our Facebook page there, and I'll weave them into our conversation so that Asmerom can answer your question. So that's incredible news. So you've talked about looking at biomarkers, you've talked about finding existing drugs to be able to treat these and then being positively reacting. So now you're at the stage of a clinical trial. So what are the timings around that clinical trial?
It is really depend on the securing funding, because we have finished our drafting the proposal of the clinical trial in collaboration with the medical oncologist, and it's a matter of securing funding, and it might just take 1 or 2 years to have funding, because we are negotiating with the pharma to sponsor for the drug. Yeah. But yeah, I mean, we couldn't sure unless it is been proven.
Yeah, absolutely. So I've made that note that you're looking for funding. So we'll talk about that as another moment. But your hope then is to use this drug, and you talk about it's already approved. Is this drug used to treat other types of cancer or other illnesses?
Yeah, it is. This drug is used to treat other drugs that have similar alteration in the FGFR receptor. It's approved in cholangiocarcinoma. It is a cancer that is originated in the liver. So it's approved in also in bladder cancer, and it's approved in other cancers also, such as leukemia, and it is well tolerated. And we are hoping to, because we found that the fibroblast growth factor also involves in modifying the immune system and the immune tumor microenvironment. So we are planning to combine the fibroblast growth factor receptor inhibitor with immunotherapy, and it could be more effective. And there is a good signal that suggested for its effectiveness also, because there is another drug called lenvatinib. This is a vascular growth factor inhibitor, or the vascular growth factor inhibitor, and it's combined with immunotherapy, and the result is quite significant. But the problem is there is significant toxicity with this combination, because the drug is not clear as the FGFR inhibitor. So we are hoping the our choice of treatment is less toxic because we have proven this in mice. It is well tolerated, and it is likely will be better than the current treatment combination.
Well, I mean, that's amazing that you've got this far. So let's see what we can do to help you secure some funding, because if you can provide a drug to patients that aren't responding typically due to normal treatments, and the existing drugs have very high toxicity, wouldn't it be phenomenal to give these patients a chance of life through this less toxic treatment as well? Amazing. Well done. Thank you for your work.
Thank you for on your usual support.
And then just touching on a word that some people may not have heard here, but organoids. Can you tell us a bit about what organoids are and how you work with them?
Thank you for bringing this hot topic. So basically, the organoids are small miniatures of tissues that are grown in petri dish, and they are usually taken from the patient tumor.
Mm-hmm.
The advantage of this in vitro or ex vivo approach is they are really mimic the patient tumor. They just represent the patient tumor, because the traditional way of screening drugs or drug discovery was based on cell lines, meaning the cell line just you culture for decades, and there are a lot of obstacles because they do not really, at the end of the day, represent the patient tumor. So we are out of the box of this challenge and moving to developing organoids from direct loops of the patient, and then growing them in petri dish, and then do the drug screening, especially for, in our case, in endometrial cancer, in a setting where the metastasis is our major problem. There is no models that represent this kind of tumors. Now, with the help of this research grant, we are developing models from the metastasis or the area that is spread, and then grow in petri dish, and then do drug screening, and then hopefully to find more effective combination therapy.
So let me just repeat that to make sure I understand, because this is phenomenal. So you're taking the affected area, some of the cells, you're putting from a patient, you're putting them in a petri dish, you're growing them to have an exact human model of that patient in the petri dish, and then you're testing drugs on that. So you don't actually have to test the drugs on the patient to see what the impact is.
Yeah, exactly.
That's incredible. That's absolutely incredible. So you're using some of this money to be able to do that in the hope that you can have better treatments for these patients without actually impacting their health even more.
Yeah, that is the objective of this research project.
Wonderful, thank you. We've got another 5 to 7 minutes with Dr. Asmerom, so if you do have any questions, please pop them in the chat. So Asmerom, you talked about the importance of needing funding. We know how important it is for ECRs. We also know how underfunded the research is in endometrial cancer too. So from your perspective, how important is that money, not only to your existing work, but also to help enable you go to this clinical trial as well?
Really, the funding is very instrumental and crucial in progressing and pushing forward the research, because it is, if you have no funding, it's like a handicap, so you cannot do anything that is really important in your research project. So I could say this is very instrumental, and it will really lay a ground for proceeding to another scale of the project. And likely, if you establish a project, it is likely also to impact more and generate good data and just to convince that your project is really critical and important.
Yeah, absolutely. Thank you. You also, I just got a question here about collaboration. So you touched on how when you were looking at patient samples that came from an international cohort. Are you working with any other teams or institutes across the world on this work?
Yes, we have very extensive collaboration. This is also established with my previously established with my supervisor. A wide network of collaborations with clinicians and the researchers interested in endometrial cancer. We have collaboration with the University of British Columbia from Canada. We have collaborations in Europe from Netherlands and the UK. We have collaborations with labs working in endometrial cancer in Spain. And we have very helpful and collaborative clinicians in nationally and supported by the ANSCOG, the Australian New Zealand Gynecological Oncology Group. And the most important is the matter hospital is very cooperative and really pushing forward for all this behind the scene.
Wonderful. That's great to hear, particularly as this cancer is cancer where incidents are growing as well. Just want to talk about what drives and motivates you. You know, you have a very big problem you're trying to solve. What excites you? What gets you out of bed every day when you go to work?
Yeah, I mean, the motive force is the patient's determination and hope. You know, they just still they are very determined to fight their cancer. This is an important aspect of my work. So I need to help these patients that are really looking for innovative and then best effective treatment, and one day to hope to come with my dream.
Well, thank you. You're obviously getting a step closer with your work and particularly getting towards that clinical trial. Just before we wrap up, is there anything else that you would like to talk to us about or raise that we haven't covered as of yet?
I think most of it is said. Yeah, but I would like to mention that patients with endometrial cancer are really stuck and they have limited treatment option, and they're also being less advocated and less funded and less researched. They are really in pain because most of the cancers are really well funded and then well researched, and they have a lot of options for therapy.
Yeah.
And however, in endometrial cancer, it's not the case. So we feel the pain of the patients, and we need to increase our effort to increase the awareness of endometrial cancer to address all these issues.
Absolutely, thank you. And I don't think you could have said that any better, that you feel the pain of the patients. Thank you for your time today. Thank you for the work you do and your team do. Takeaways I have are the phenomenal progress you have made on what is a underfunded cancer, a cancer that has some very dramatic treatment plans that still in 2023, some women have to make the choice between having kids or living. A cancer that is growing due to the population and obesity levels as well. Yep. But also on the positive side, the work that you and your team are doing around the organized and growing treatments outside of the human body. And more importantly, your steps to being very close to a clinical trial for those that aren't receptive to current treatment plans and those that have had metastasized cancers. Thank you for your work. We really do appreciate your time today, Dr. Sengal.
Thank you. Thank you for creating this opportunity and sharing my experience in the research area. And thank you for the funding and for the donors and behind of Cure Cancer in the community.
Look, it's our pleasure, and I'm making a note here that we'll look to see what we can do to help you get closer to that clinical trial as well. So thank you. Thank you to all of our listeners, our donors, and our fundraisers on the call as well. I hope you found that just as inspiring as I did. And don't worry, we will keep in touch with Dr. Sengal as he goes through his research to get further updates as well. Please join us next on Thursday, the 8th of June, again at 12:30, where I will be chatting with Dr. Danielle Bond from the University of Newcastle on her work on acute myeloid leukemia. So until then, have a wonderful afternoon and take care. Thank you.
Thank you.